And go ahead.
You can just go for it.
Alrighty guys, thank you guys for joining. Thank you Miles for having me here to help provide a little bit of education for our volunteers that have so graciously volunteered to help get this place going and up and running. So my name is Ida Gonzalez. I'm a nurse by trade. I am a hospice operations specialist. I have been in hospice for about 20 years or so. I have done everything from the field nursing part of it, taking care of patients at bedside, to being executive director of a couple of hospices in town. So today, the purpose of the presentation is to provide some education on medication administration so that you guys as volunteers caring for the patients that will be here feel comfortable and confident in being able to administer medications. Okay. We have, I think, did Miles give you guys the handout that we'll go over?
Yes.
Alrighty. We'll go ahead and, let me find my glasses now, put in a pocket.
Hi, how's it going? Good to see you.
So today we're going to talk about med administration for caregivers. I don't know what background the caregivers that are going to be here are from. They're all from, I believe, no medical background to maybe some nurses, so it'll be a combination of volunteers that they have here. So we're going to talk about med administration for caregivers. It's a little bit different than for nurses. For caregivers, we say there's the 5 rights to ensuring proper med administration. For medical professionals, there are a few more than 5, but we're going to go over the 5, and then I'll mention to you guys the others that are also part of the rights. Those came later on, and like I said, they're more geared towards nursing background. Okay. So we'll go over each of the 5 rights. The first one is the right patient. We always want to make sure that we have the right patient in front of us. Here, it's a small setting, it's a residential setting. We aren't going to have a lot of patients at one time anyways. So the caregivers will pretty much know who the patients are in which rooms. But you always want to identify the patient if they can speak. Of course, their name, date of birth, if they're able to speak. We are anticipating that the patients that get here may be close to nonverbal or maybe nonverbal. So then at that point you would identify them by, other staff members, looking at their chart, if there's a picture in their chart, and comparing it to the patient that's in front of you. If they are able to speak, it's very easy to confirm who they are, but if they're not, you've got to do a little bit extra. Number 2 is the right medication. You want to check the medication order and make sure that the medication name on the order matches the name of the patient, right? You want to verify the name and the date of birth on the medication order. You want to look at it very closely because there are some names of medications that sound similar to other meds. Now, by the time our residents get here, they are probably going to be on comfort meds only, right? Because the qualification to be here is somebody who's close to end of life, which is typically, last 2 weeks or so of life. At that point, you're going to have patients that have a decrease in eating. Maybe they're not eating at all anymore. A decrease in their swallowability. Less food with a lot of medication is not good. That alone can cause some discomfort. So at the point of them getting here, they are probably going to be on a limited number of medications, which we call comfort meds. They're pretty similar, and I'll go over, I was going to list them and I failed to do so, but I will go over the most commonly used medications in hospice at end of life. Okay. You want to make sure that you're administering at the right time. Some medications will be ordered twice a day. Some may be ordered as needed, depending on what the symptoms are of that individual. In hospice, we are treating the symptoms, no longer treating the disease. So how the patient looks, does the patient look comfortable? Does the patient look like they're in pain because their face is grimacing or their forehead is tight? Those are indicators saying somebody's not comfortable, right? If they're fidgety, if they're restless. So some medications may be as needed. You know, if the patient is calm and managed, we don't want to over medicate anybody. We are only giving the amount of medications to make this patient comfortable. Okay, so the times that you guys may be administering may change rapidly depending on what's going on with that patient. Since all the patients coming here will be on a hospice service, you have access to call that hospice, right? If the patient is not comfortable, you see that the current medication regimen is not working for them, you guys can call the hospice, speak to the hospice nurse and let them know what's going on. And then they would, I'm not sure what the legalities are, Miles, because this is a different setting. If they could give orders over the phone, letting the caregiver know to change the frequency of a med or to change the dose of a medication. I don't know if the caregivers are allowed to take those orders over the phone or if the nurse is gonna have to come here, but that's something Miles can elaborate on.
Yeah, I think in that situation, for those volunteers that we have who come from a healthcare background, maybe our doctors or physical therapists, nurses, I can delegate that type of, I guess, privilege or special ability that they have. So in that situation, I'm an RN myself.
You're a nurse as well. Okay,
Yeah,
okay,
yeah, so
so
I can do that.
very good. Okay, very good. And then number 4 is the right dose. You always want to make sure that the dose that you're giving is what the label says and what the order says. So initially when you first meet a patient, it's a good idea to look at the doctor's orders. You should have orders for every medication that's in the home and read the order and make sure that it matches the order that's on the label. Okay, you want to make sure that it has the right name. There have been instances where a pharmacy has sent a wrong medication to a patient, so sent a medication out with a different patient's name on it. Had that spouse not read the name on the bottle, she would have administered somebody else's meds. So while there's a lot of safety checks in place to ensure that the right medication gets to the right patient, these are functions that are carried out with humans, and so humans make mistakes sometimes. So to try and avoid those mistakes when you first meet a patient, I would say that it's a good idea to look at the orders, look at the labels, just to make sure that they match. Eventually you'll know the patient, you know, after caring for them a couple of days in a row or for a couple of days. And then the right route. For this setting, it's probably all gonna be oral from the caregivers, oral route of medications. There's a couple of different oral routes. So oral could be swallowing a pill, or it could also be buccal, which would be the inside of the cheek. A medication such as the liquid morphine that's used at the towards the end. Well, not only towards the end, I guess liquid morphine can be used throughout somebody's hospice stay, but it's a common medication we use that's great at symptom management. That medication can be given just to the inside of the cheek. If the patient can no longer swallow, the inside of the cheek is where it has to go, and it's absorbed through the submucosal lining in the cheek, works pretty quick. So oral, buccal, or subbuccal, which means under the tongue. Some medications such as a hyoscyamine, which is used to dry up like saliva if there's excessive secretions, that can be given in a pill form under the tongue, and it's like a rapid ready tab that just disintegrates. So those are the 3 methods that you guys would more than likely be using to administer medications. Knowing the 5 rights of med administration can help you avoid medication errors. Even though steps are taken for proper med administration, errors can happen. Be sure that you report any error or suspected error immediately to Miles. Please don't be afraid to report that error. If you have discovered that maybe there was some type of error, or even if you're unsure, get with Miles immediately to discuss. Sometimes there's no adverse effects to what happened. Other times there may be. It just depends.
We have 2 people check the dosage, right? I mean,
When it comes to the narcotics, the controlled substances, we will have the 2-person check for sure, and that's in the documentation. When it comes to the other medications, we don't need to have a 2-person check. but we do want to try to have somebody who has experience with somebody who doesn't have the experience, kind of partnered up, so it can be two people fairly often too. And I just want to emphasize, if there's an error, you know, this isn't a culture where we're out to punish people, get people in trouble, you know, where you wouldn't be able to come back if that mistake happens. We all make mistakes, professionals make mistakes. It's just kind of a normal thing. So really that transparency, that openness, it's not punitive. We're not here to, you know, punish.
Right,
so
we simply want you
really-
to report that so we ensure the outcome for the patient is not negative.
Yeah,
But
exactly.
as Miles stated, it's something that can happen to anybody regardless of how many years of experience they have. So don't be afraid or nervous to let somebody know. And there will always be two caregivers, or
Yes, I mean,
okay.
you may have that kind of emergency situation where one has to leave.
But for the most part.
For the most
So if
part,
you're
yeah.
unsure of anything, please get with your colleague that's here, you know, or even a phone call, whatever
Yes.
process Miles has set up. But I'm almost 100% positive that nobody has ever left here to try and make decisions on their own. There's always somebody that's accessible, or even if it's a phone call. So
Correct.
instead of second guessing yourself, an easy phone call will help. And as you do this more, you'll get more comfortable with doing it. Let's see, other things to consider when administering medications is this medication needed, do you need to administer it with food? Some medications say take on an empty stomach, some say take with food. Does this medication need to be separately given from other medications? And you guys don't have to make those decisions. The nurse that's following that patient should be giving you guidance and education on those things as well, okay? You also want to make sure that if you're using any type of devices to assist with the med administration, let's say an inhaler, if somebody needs a spacer for their inhaler, make sure that you're just looking at the equipment, you know how to use it. If you don't, ask for help. Typically any accessory that comes like a spacer for an inhaler will have written instructions in there on how to use it. So if you have any questions, don't hesitate to reach out. And then you also want to be aware of the patient's allergies, because sometimes the pharmacy might miss that too, or the nurse might miss that. So when reading the patient's chart, just try and pay attention to allergies. Does this patient have any allergies? If you see they have an allergy to morphine and then you have an order for morphine, it's okay to question that. It may not be a true allergy, but just questioning it, asking, is it okay to still give this because it states it's an allergy? Sometimes people think they're allergic to certain medications, and it's not a true allergy, but it's help me, Miles.
Yeah, it's a side effect.
A side
of
effect.
like,
Yes, a side effect.
Yeah,
a
it's
side
like
effect.
an unpleasant side effect.
Right.
For them, yeah.
Right, such as morphine. A common side effect of morphine is increased drowsiness, right? It's not that they're allergic to it, it's that that's the side effect of it, okay? So be sure and check for allergies as well. Additional rights, so those are the 5 rights. Make sure you have the right patient, the right medication, you're giving it at the right time, you're giving the right dose. So if it says 1 pill, do 1 pill. If it says 0.50 mils, make sure that you know how to use the dropper for 0.50 mils, because it is common to give liquid medication towards the end of life because they lose the swallow ability or their level of conscious does not allow them to take the medication. So it's common to use liquids, okay?
And what we're asking hospices to do is to have the pre-filled syringes to
great.
make it even easier on
Great.
us as well, because some of those measurements are so small. We just, we don't need that extra burden on us to try to get something so close and accurate. So we put that in the professional's hands.
That's great, yes,
Yeah.
that's great. And all assisted livings here in town, they require that as well. That the medications come in pre-filled syringes so that the person administering it doesn't have to try and look at the little lines on those syringes and try and get an accurate dose. So an instance where that might be you know, if the medication that you're giving them is not enough, if they change the order, something like that. So just always be aware of the syringes, even if you're not drawing them up, just look at them, become familiar with them, okay? And then the right route. So those are the 5: patient, medication, right time, right dose, and right route. For you guys, the route will be all oral. Let's see, the additional rights that we can talk about that are for, typically for people who do have a medical background, such as a nurse, or is right documentation, but I believe you guys will have to document as well. Are you using an electronic or is it a
I
handwritten?
think it's a handwritten.
Okay,
Yeah.
so just ensuring that any medication that is given is documented, especially the narcotics. You want to document the time that you gave it, so that way you don't have to think by memory, well, is it time to give it again, or when did I give it last, or so. Documenting each time you give a medication, whatever process Miles has set up. Right education, so with the medical background, you want to be able to provide education to the patient and family on what the medication is, why you're giving it, how it works, what the intended result is that we want to see. The right assessment, so regs state that only an RN or higher can do an assessment, so an LPN it's not in their scope of practice to be able to assess a patient. You, in your setting, will still be doing some type of assessment, even though it's not an official assessment, but you're going to be the ones with that patient in front of you, seeing what symptoms that they are showing, whether it's they're showing agitation, pain, just an unsettled patient. You're going to want to call and report that to the nurse, right? And you're going to have to be able to do some type of assessment by saying, this is how they look. And it doesn't have to be medical, like, these are the vitals, it can simply be in very layman's terms, like, he's kicking his legs, she's flailing her arms, her forehead is super tense. Those non-medical descriptions are definitely an assessment, right? That would be appropriate for you guys to be able to relay to the hospice nurse. And then the hospice nurse at that time, in collaboration with the team, makes decisions on whether meds need to be changed, doses, frequencies, things like that. Okay? So always know that you're supported by the hospice nurse 24/7. All hospices are required to have a nurse on duty 24/7 available to answer a phone call. So if it's 3 a.m. and you're not sure what to do, I don't know what Miles has instructed on the process, but just so you know, there's always a nurse to call if you're unsure of something. Okay?
And we'll also have someone on call, probably myself or a board member on call around the clock in case you're not comfortable calling a hospice directly or just kind of feel uneasy, then we're there all the time too.
The next one is the right reason. You want to be able to explain the reason that you're administering the medication, right? Whether it's to patients or families. The patient also has the right to refuse if they are if they mentally have the ability to refuse the medication. They do have that right to refuse as well. Sometimes it may be just for that moment, and if you redirect them or leave and then come back, they may be in a different state of mind and agree to medications. And then the right evaluations. You want to be able to evaluate, did the medication work? After I gave them the medication the nurse told me to give them, did their forehead relax? Did they become relaxed? Did their arms become relaxed? So you want to be able to evaluate if the interventions were appropriate. Okay? Any questions?
The medication is administered within the eye.
You won't typically have end-of-life medications that need to be administered in the eye, but if you see the second page I gave y'all was routes of administration. I highlighted the most common routes in yellow.
Oh,
The other ones are just for your knowledge, but you may occasionally have to do an eye drop, but I wouldn't really anticipate that's going to be a whole lot.
okay.
I think they would be allowed to do it, but I don't think that you would have a whole lot of eyes, ears, nose, things like that. So the routes highlighted in yellow are the most common routes of medication administration in the hospice setting. The hospice philosophy states that we attempt to use the least invasive interventions, methods, and treatments possible to manage symptoms and support quality of life. So when we can, we want to give medication orally or topically. That's the least invasive method possible, right? When those methods aren't either a choice available or appropriate at the time, then we look for other routes of administration, which you guys would not be doing. Let's say, for example, if the patient needed a suppository, if they needed any other injections, a subcutaneous injection or an IM injection, those are not medications you would be given. It would be the hospice nurse. And we don't typically give injections in hospice. You can typically manage symptoms with our oral medications that we have available. Okay. So the first one that we talked about was oral, the medication given by swallowing the dose. Buccal is the inside of the cheek, and the medication is absorbed through the submucosal lining. It does take effect pretty quick, it doesn't, for instance, the liquid morphine that we give. It works within 15 to 20 minutes. It's fast acting, but it doesn't last very long. So these medications that are given orally may have to be given a little bit more frequently than a long-acting pain med would. And then we talked about sublingual. The medication is administered under the tongue. Topical. There are times that we use topical medications. At one time we used the ABHR cream quite a bit, but a lot of studies have shown that its absorption rate is not high enough to be effective to manage symptoms. It just depends. That ABH was a topical cream with a combination of medications, Ativan, Benadryl, and Haldol. Ativan, Benadryl, and Haldol. It's a compounded medication that's put on topically. It's not used as frequently as it used to be in hospice, but sometimes if we just can't get the patient managed, we'll use something like that. Let's see, and then we have transdermal. The most common transdermal medication I've seen used in hospice is a fentanyl patch. They're not used real often because, multiple reasons. One is they have to be absorbed through your subcutaneous fat. And most of the time, hospice patients at the end of life don't have a lot of fat on them. They're very thin, they've maybe lost weight, and not everybody, but in general. They have mostly bony prominences, and the fentanyl patch, the way the medication works is it's absorbed through the fat. So if there's no fat, it's not going to be absorbed. So that's one of the main reasons it's not used as common. You would think that it would be a good alternative because you put the patch on and forget about it until 3 days later, because they're typically changed every 3 days. But they're not as effective for pain management, definitely not as effective as the liquid morphine. And then they're very, very expensive. The fentanyl patches are very expensive. And of course now with the fentanyl crisis we have, it's a lot of people are very nervous about the word fentanyl. They used to be very nervous about the word morphine. And these are medications that were, of course, their original use is for pain, severe pain management. We're not talking about a little headache, or we're talking about pain that's anywhere from 6 to 10 on the pain scale. Transdermal is not used a whole lot in hospice. Okay. The others are listed there, but just really for your, and there's many more outside of this. When I was doing research and saw how many routes of administration there is pages and pages. This is what's most applicable to you. Okay.
It might not really make sense intuitively, because we're thinking, okay, when we take a medication, it's gonna get into our gut and we're gonna digest it, it's gonna get to the rest of our bodies. But it's pretty amazing We have blood vessels in the cheek, like she was talking about, capillaries that are so small that do collect or receive that medication directly, and it goes right into the blood flow. And same thing for the skin, that's how it works. It gets into the blood, and the blood of course goes throughout the body, so that's where you can get a whole body effect from something that's just put on the skin, or something that's just put into the cheek.
So if you are administering anything that's topical, you want to make sure to always use a glove, because whatever gets on your hands is going to absorb as well.
Great.
So you want to make sure that you're using gloves. If you're administering the morphine, make sure that you don't get any on yourself. If you do, wash your hands immediately, because it will absorb just like it's meant to for the patient. Let's see. So I didn't list the most commonly used medications at end of life, and I apologize for that, but I'm going to go over them with you guys. So most hospices order what's called a comfort pack. Not all of them. This used to be popular way back in the day, ordering a comfort pack. It was a little pack of medications that we ordered that came in a little box, and we would tell families, put this in the refrigerator until I tell you to take it out and use it, okay? The medications that are typically in that comfort pack are liquid morphine. Some people call it Roxanol, but it's liquid morphine. The strength is typically 20 milligrams per mil, and the dose to administer can vary widely. So, it's typically starts at 0.25 mils every 2 to 4 hours, depending on what's going on with the patient. But your liquid morphine helps with pain relief, it helps with respiratory distress, and it really gets the patient comfortable. It relaxes the lungs enough so that they can breathe for when they're having trouble breathing, and it really helps with severe pain management. As people get closer to the end of life, their nerve endings become very sensitive. So even like the weight of a sheet can cause pain to the body. Even like, when you're sick and you're in bed for maybe a day or two and you get out of bed, like your back hurts and everything hurts. So you can only imagine once you become bedbound and you're in the bed all the time, you're gonna have pain from just being in bed. So you can probably expect that the majority of your residents will have morphine to help manage those symptoms. Your next medication is lorazepam. Lorazepam is a benzo that is used to treat anxiety. Anxiety can also cause shortness of breath, and then shortness of breath causes more anxiety. So it's kind of like a vicious circle. So lorazepam can be given along with morphine or staggered, depending on what regimen the doctor has ordered. But lorazepam is very beneficial to help with anxiety. It also helps with breathing because it relaxes the patient a little bit, so they allow those breaths to come more naturally instead of struggling because they're anxious. Your next medication is haloperidol. Sometimes they refer to it as Haldol. That is used for what we call internal agitation. It's a little bit different than anxiety, and it may be hard to identify, but it's another medication that we have that typically comes in liquid. The lorazepam can come in liquid or pill form. The Haldol typically comes in liquid, and that's used for internal agitation. Frequently, patients at end of life have this internal agitation going on. Not all, but some do. So we have the hyoscyamine available for that. And then
The haloperidol.
The haloperidol, I'm sorry. The haloperidol. The next H medication is hyoscyamine, I'm sorry. And that's where it can get confusing, right? Like, is it haloperidol, hyoscyamine? I don't know, they both start with an H. Haloperidol is for internal agitation. Hyoscyamine is for excessive secretion, so saliva. Sometimes if your patient is having difficulty swallowing, they can't swallow the saliva in their mouth, so we give them a medication called hyoscyamine to help dry the mouth out a little bit. The lorazepam and the morphine will also do that on their own. It dries out all of the orifices. hyoscyamine can also be used for what's called, some people call it a terminal rattle, or it's a rattle that you may hear when somebody gets close to the end of life, and it's almost like you can hear it right here, and that sound is very disturbing to families, that the rattling sound. So the hyoscyamine helps with that sound as well. So if you ever happen to see that symptom, you know, if the nurse hasn't instructed you to use it yet, make sure and reach out, let them know they're having this symptom, then they can let you know what to use and how to use it. So that's the hyoscyamine. And then sometimes we'll include a Tylenol suppository in there, which you guys would not be administering, but oftentimes at end of life, people get a temperature, their body gets very hot. And so if it seems to be causing any discomfort, like agitation or any discomfort, we want to go ahead and try and treat the temp. If the temperature doesn't seem to be having any adverse effect on the patient, it's not really that important to treat it. But we do have the Tylenol suppositories as part of that comfort pack. Every hospice is different. Some still provide them, some don't. It just really depends on what hospice you're working with. Those are medications that we typically use to manage the symptoms that we see, the common symptoms we see close to the end of life. When somebody gets towards the end of life, we can expect that they're gonna have little to no intake, whether it's fluid or food. They're gonna have little to no intake, which is normal for that time in their journey, right? Because as the body is transitioning from living to passing, you no longer need nutrition to maintain energy and those type of things. In fact, eating takes a lot of energy that most of us don't even think about because we do it and it's an involuntary, I know eating for me is involuntary oftentimes, but we don't even think about it. But it takes a lot of energy to process foods, especially meats. So more than likely by the time patients get here, they are not going to be eating meats for sure, because it takes a lot of energy to process meats. So you typically see meats be the first food group to go out the door as somebody declines, and then it's veggies, and then it's fruits, and then it's soft foods, and then they may get to the point where they're not eating at all, which is okay for this time in their life. Now, it wouldn't be normal for a healthy 50-year-old person, but for the time when somebody gets close to end of life, decrease in intake is considered a normal process for a normal passing. Sometimes we have families say, but they're hungry, but they're thirsty, and so really being able to have that background to explain to them and educate to them why we believe that they are comfortable and food and water are not a priority right now. Really getting families to understand that we are treating the symptoms of their loved one. So how their loved one looks. If their loved one is laying in bed and looks peaceful and comfortable, that's what we're shooting for. Peace and comfort. Of course, quality and dignity till the very end, right? As much as we can provide. What questions, if any? It's a lot of information. I know it's a lot of information, but I hope that you guys feel supported in knowing that you always have somebody to reach out to or to call.
This is one of those things that you cross when you cross that path, and you deal with it.
Yes, yes, because everybody's dying experience is different. We can more or less educate and guide families on what we anticipate we're going to see because they're common symptoms that we see. But there's some people who just don't follow those common symptoms that happen at the end of life. For the most part, they are common amongst most. And then close to somebody passing, typically 24 to 48 hours before somebody passes, they will be non-responsive. They will no longer respond at all. You won't be able to wake them up. At that time, people feel like, okay, we don't have to give the medication anymore, they're not responding anymore, but it's important that if ordered, you continue to give the medication, because those symptoms aren't going away. The pain is going to still be there, the respiratory distress may be there, so you, as long as the nurse has ordered, you want to continue giving, especially the morphine is what we typically give till the very end. Because even though this person can't verbalize pain or discomfort, we can anticipate that they are having some pain or discomfort during this process. The goal is really that they pass peacefully and have symptoms managed as best as possible.
Now, Ida, there might be some concerns that come up with something like morphine. We know that there's a lot of misunderstandings about even what hospice's role is at the end of life. This idea that hospice kills people, or that these medications killed somebody. Could you maybe help address that?
Absolutely. So we never prescribe more medication than what's needed to manage the symptom. So if you're following the doctor's orders, you don't have to worry about an overdose. These medications, if used as prescribed, are wonderful. They are, I don't want to say lifesavers, because this is helping somebody be comfortable, but they really help support the end of life comfort. We never give more than is required to manage the symptoms. So the doses we give are nowhere close to what it takes to overdose and cause somebody to pass away. And that's why the frequent nursing visits are required when somebody's close to passing and they've been identified as somebody who's close to passing. Typically within a week or so, a nurse can tell that this is happening. Daily visits take place. For the most part.
If it's a as needed dosage, is there a time limit on that?
It just depends on what's going on with the patient and with the medication, what medication it is. But I don't know how as needed is going to work here, because you guys, don't have that assessment ability, and typically an as needed medication is based on an assessment, right? So I'm not sure if you're going to allow as needed medications, but you will have direct guidance. So if it's as needed, they're going to say as needed every 2 hours, or as needed every 4 hours. So there will be an exact order stating how often it needs to be given. Yes, there will it won't ever be just as needed, and you can give it. There's always a time limit, a time frame that you can go by, and that's why documenting when you give it and the time is super important. That way you can reference your documentation and say, okay, well, I gave it 2 hours ago. And then it also helps the nurse to come in and look at this and say, okay, well, he's pretty much getting it around the clock every 2 hours, so let's just go ahead and schedule it, so that we take that burden off of the staff and saying, oh, do they need it? I don't know if I should give it or not. And because it sometimes can be nerve-wracking to the staff that's giving the medication, because you want to make sure that you're not going to cause this person to pass prematurely, right? So as long as you're following the doctor's orders, they never give more than what it takes to manage a symptom. Okay? Yeah. And so as long as the medication follows doctor's orders, they work wonderful to manage the symptoms that we're trying to manage. It does have a bad rap out, because there's been so many issues with drug addiction and so on, and so it does have a bad rap, but it's what the medication that's used most commonly at end of life. Hospices do not believe in giving patients medications that will cause them to pass.
Yeah, that's an important distinction and clarification for us, especially our values oppose medical aid in dying or physician-assisted suicide. There is a big difference between these medications that we're talking about today and using them as ordered for comfort.
Right.
Think about, according to Catholic teaching, we should alleviate suffering and pain.
Right.
And that's exactly what we're talking about here is helping somebody where they have one less thing to think about as they're at their hour of death. They don't need to be thinking about pain or having these anxious thoughts. They can instead be having this peaceful experience and, God willing, drawing close to that good death and that ending, so that they will have peace and on the other side of it, God willing, be in heaven in everlasting life. So,
And a lot of people do have that misconception that hospice just comes in and will give their loved one a medication to make them die, and that's we support the best quality of life for as long as possible, so we do not want our patients to pass prematurely if that's not their time. We want them to be able to enjoy life for as long as they can, and so we definitely support that. And I say hospice, whatever's going on with this patient is going on with them. Hospice does not cause the illness. Hospice does not exacerbate the illness or make the process happen any faster. We're just on the bus along for the ride to help with guidance and education for the caregivers, the family members, the patients themselves, because this can be a very scary time for people, and this can be a very scary time for loved ones with all of that comes with seeing your loved one decline and approach death, right? Death is really hard for a lot of people to talk about. And I think that as we educate our community more and educate people in our community, that they have a better understanding that we are just here for the guidance, so that you don't have to be scared, so that you do have somebody to reach out to 24 hours a day, 7 days a week, whether it's Christmas or whether it's Valentine's Day or just 2 in the morning on a random Saturday. You have support, and that's what hospice is all about. And it's evolved a lot. It's evolved quite a bit, and that's a whole nother discussion. That if Brian ever wants to invite me back, I love educating on what hospice is, what we do, how we can be a real valuable piece of the journey, and so we like to be able to support that, and I like to give back to the people in my community, knowing that it could potentially be my neighbors, my co-workers, myself, or my family, and I would want to have the very best guidance and care possible at that time.
For sure.
Any questions?
When did hospice actually originate? Do they have a date they can?
It was like in the 1950s or so, and it was originally created for cancer patients that were dying like now, that were very, very ill. And so that was the origination of hospice. It's evolved quite a bit, and there's so many diagnoses now that can qualify somebody for hospice, from any body system, cardiac, respiratory, mental. There's a lot of different diagnoses, and a lot of people don't realize that either, like they don't have to be passing to date. In fact, we want to get people on our service prior to them like actively passing. That's when they benefit most from hospice, most from the guidance, help with that peaceful transition. And not only do we have nurses, but we offer social workers, spiritual care disciplines. We offer a caregiver that helps to come in and help the patient get cleaned up, because that's part of dignity, right? Ensuring that you're clean and dry and free of odors. And so there's a whole team, a collaborative team that works together to help get this patient feeling comfortable, right? And so think of going on a journey on your own that you don't know a whole lot about, or going on this journey with somebody who's experienced many, many of these journeys that can help with guidance. And like I said, we're not always right. We can sometimes state, we believe this patient is close, and then the patient has this, uptick. And so we give our, just like doctors do, right? We give our best educated guess based on other cases that we've seen in the past.
Yeah, I love that intro to hospice too. And we will have more trainings on hospice specifically too, and it'd be great to have you even come back and give one of those. In the comments, Heather Ray says hi,
Oh, hi Heather!
and a number of other people are watching. So, Lori, thank you so much for the question. She mentioned, and I'll start off by answering it, and then you can add on. She mentioned that when somebody is in the end of life, we look at what the symptoms are that they're experiencing, and we don't always, the first thing that comes to our mind really shouldn't be, let's give a medication. We should be looking at, maybe they've been in the same position for a long time. They just need to be turned. Or changed, right? So this class, we're focusing on the medication because, that's the topic here, but it can't, medications can't replace just good common sense and good just attentiveness to the person's needs. So we can start with those basic things, and there's a lot of pain relief that we can provide in non-medical ways, including just repositioning. So.
And maybe that can be a separate class, like non-pharmacological interventions to manage symptoms, right?
Or massage of some kind.
There's a lot of other interventions that can be tried, because of course it's, least invasive method possible, right? So always keep that in mind. We want to do the least invasive method possible. So sticking somebody with a needle is not least invasive. Really the oral or topical route is least invasive. And I've done this for a long time, and there was only one person that I could not get managed with the current methods that we have, and that was my dad.
Oh,
So we work hard to ensure that we provide the relief that's needed.
Medically and non-medically, like you're
Right,
saying.
spiritually is so important, to witnessing many people pass, right? Over the 20 years that I've done this, I see that people who don't have a faith sometimes tend to have a little bit rougher exit. Sometimes to manage that agitation or anxiety, all they need is to meet with our spiritual care coordinator and have whatever discussion they want. It can be non-denominational. We really like to individualize our care, so not everybody's gonna need or require the same amount of care, right? We really like to individualize, what does that person need? And sometimes it's just to meet with our spiritual care coordinator to help with whatever struggles they've had, because they don't have any type of faith base or a higher power that they believe in. And so in my own opinion, this is no data behind it, but in my own experience, people that do not have a faith tend to struggle a little bit more at the end. Alrighty guys, any other questions, Miles?
Let me go double check the stream and see if
That
anything's
looks
coming
different as
through.
well, something changed on that just within the last.
We should be still done. Maybe we should be good.
Cool. I'm gonna go check that real quick if you have any questions.
what about people that get better and rotate out?
Sometimes people get better when they come onto hospice, and sometimes it's temporary, sometimes it's, a little bit more long-term. Just think, if you have the support of a nurse and an entire team coming to your house every single week, couple of times a week, we catch infections sooner, we catch issues sooner. While we don't do diagnostic testing, we do assess the entire patient and what's going on with them. So sometimes people get better just coming on hospice, they're getting better care. Maybe if you have an individual who lives by themselves that nobody checks on, now they have somebody checking on them, ensuring they're eating, remembering to take their meds and so on. So we do discharge patients at times.
Does it happen a lot?
It doesn't happen that often. But it does happen. Now by the time the residents get here, that more than likely
Won't happen.
won't happen, but you know what? That's just my best educated guess. Over the course of my hospice career, I've been asked, on more than one occasion, like, how much time does my loved one have? And my response the first time I was asked that is, nobody can give you that information. If I could tell you the date that your loved one was gonna pass, I would be making way more money than I do now.
Yeah.
Nobody knows that for sure, not even the doctors do, because it's just, there's a higher power than us here.
Yeah, that's so powerful. Every death, you already said this too, is unique. The timing of it, we can't tell. It's such a mystery, and we don't. Somebody who you probably seen this, or somebody who you know should have died. They end up period ends up lasting a lot longer because they still have one more person to see. Or something needs to happen that maybe we don't understand, or maybe it needs to get to midnight, so it's a day that's really important to them.
Or closure of some kind. They need some type of closure. So when somebody's hanging on like that, we oftentimes, ask the family, is there anybody you think they're waiting to see, waiting to hear from? Even when somebody is no longer conscious, they say hearing is the last sense to go, so they can still hear what's going on around them, and so you want to be sure that you're saying whatever you want them to hear. Don't mind them hearing, and things that maybe you don't want them to hear, to step away where they're not in, where they can't hear you. It's unfortunately different for everybody who passes, but when somebody's hanging on, we look at those things. Is there somebody else they're waiting to see for closure? Sometimes family members will say, I've been sitting with them for 3 days straight, and they just, the second I walked away for something, they passed. And it's like, that may have been your loved one's own way of protecting you. They didn't want you to see that last breath they took, or whatever the case is. But I believe that things happen for a reason, and we may not know it at the time, but we have to be okay with knowing that the interventions we provided were all with good intentions and helping keep this patient comfortable in their journey to another world.
Yeah, wow, that's powerful. Lori, I misunderstood or kind of quickly read your comment before, so she clarified and said mainly that we can look for nonverbal cues for pain or discomfort. Right, because like you mentioned, we're going to be having people here who aren't necessarily able to say, I have a pain of 5 on a 0 to 10. So right in each of the charts here, we have a scale that we use. It's called FLACC, F-L-A-C-C. So we look at the face, the legs, the arms, if there's a cry or a moan, and then consolability. We can get more into detail into that, and that's for pain management, but just to know, like in Lori's example, if she was turning a loved one and they moaned during it, that's a sign that they're probably in pain even when they're not being turned. So that would be an indication that we could give them medication.
And your patient may seem comfortable until it's time to reposition them or to move them while they're being changed, because they're in that set position, and once you change them is when their pain exacerbates at that time. So sometimes, depending on what's going on with the patient, there will be an order to give that medication 10 minutes or so before you're going to change their brief or reposition them.
Great point. And one reason that somebody might be so still is because they're in so much pain too, right? They might be closing their eyes or so kind of stiff because they're so tense. So that's something we can watch out for.
You can also look at the jaw, the tightening of the jaw. If somebody's clenching their teeth, their forehead frowning, their face may appear tight, like they're just, tense. That's a good indication that they're having some type of discomfort. Okay. Thank you guys so much for joining today.
Thank
I
you.
hope it's
Thank
been
you.
helpful.
Yeah.
It has been.
Please know I'm always a resource if you guys have any questions and Miles wants me to come back. I'm happy to share everything that I know about hospice and to hope that we can all have the best support we can, because we will all be there one day.
It's good knowledge.
Yeah, that was very thorough. Thank you.
Yeah.
I appreciate it.
Good. Thank you guys.
Thank you.
Isla, which hospice are you?
I am with Q Hospice. I am not here just representing Q Hospice. I want all hospices in our community to be able to provide exceptional care, because this is such an intimate, important time that we do not get the chance to do over. So quality of care is super important to me, and so I myself run Q Hospice, but there are many great hospices out there.
Yeah.
Amazing.
Yeah, it's powerful. This dying is a once in a lifetime opportunity, and these are just some tools that we can help to make it a good
Right.
experience.
And I don't think people talk about the fear. Not everybody has fear when they think of dying, but a lot of people do. Even if you are a very religious person, even if you do have a higher power you believe in, it can be a scary thing, right? You're leaving the world that you know, and you're leaving the family and loved ones that you know, and so people are afraid to talk about death.
Right.
And I think that the more we talk about it, because we know it's gonna happen, the more comfortable we can be going into it, or the more knowledge we have to make better decisions for ourselves.
Exactly. Yeah, and that's a huge mission of Inhora, is just to get that conversation going, to be part of it, along with others in the death care industry, the death doulas and such in our community, the hospices. So thank you, Garrett. How do you pronounce his last name?
Ryan?
Ryan. Yes, with
yes,
Q
one of our
Hospice.
owners.
Yeah. He was one of our early supporters for this home when I contacted him before we had the property, when it was just an early idea. So shout out to him. Shout out to Q Hospice. And continue. We're going to have these trainings Tuesdays through April, and if they seem to be something helpful and you all like it, those watching on social media and those here today, we're going to continue this and see how it goes, so we can see about making it a regular thing for months to come, years to come. If you have topics you're interested in hearing about, let us know. I know Ida's got a wealth of information, as
Pain
well as
management.
there we go. Yeah, pain management, that would be a good one. So stay tuned, more to come. Thank you, everybody.
And thank you to Inhora for this. Like, you don't know how many patients' journeys you're gonna change by having the support, because there are some people out there that don't have anybody.
Yeah, there's a lot.
Nobody to care for them once they become completely bedbound, and hospice doesn't provide 24-hour in-home care per Medicare guidelines. And so for those that may be close to end of life and their alternative would be a nursing home or passing alone at home, like this is amazing. So thank you for you guys putting this together, and I know that the volunteers that are gonna make this place work is the gift that you give is priceless. So
Wow, powerful message. Thank you for that.
Thank
Absolutely.
you.
Are all these videos going to be on the video link?
They'll be available through the social media, and we're going to try to get them onto YouTube as well, so they can just be watched anytime. Yeah,
Like the ones I've been watching?
that's right.
Okay.
Yeah. So
See?
thanks everyone. Like us, follow us,
Thanks,
and we'll be
guys.
in touch.
Thank you.
And then for those who are here, we can have some snacks.
Like and follow. I don't have any social media, so